Welcome to the GMJ podcast, the official podcast of the Georgian Medical Journal. In this series, we present structured discussions of peer-reviewed contributions published in GMJ, examining their implications for clinical practice, medical education, and health policy. This episode reviews the article titled, Fixation of Older, Failing Heart Bypass Grafts, a retrospective study. And to kick off our deep dive for you today, I want you to imagine hooking a standard garden hose up to a high-pressure city fire hydrant.
That is quite a visual to start with.
Right. I mean, initially the water flows fine, but over time, that intense pressure causes the lining of that garden hose to warp and balloon and eventually fill with this thick, crumbly debris.
Which is exactly what we're looking at today.
Yeah, because right now, inside the chests of millions of people, that exact scenario is playing out. It's the terrifying reality of an aging heart bypass graft. So today, our mission for this deep dive is to unpack this fascinating 2026 retrospective study by researchers Ilya Debarashvili and Elad Asher.
And it really is an incredible look at the evolution of how we fix these failing grafts.
It really is. They take a huge stack of hospital data and pair it with a rich literature review to show how interventional cardiology completely re-engineered this incredibly high-stakes procedure.
Yeah, the scope of Debarashvili and Asher's work provides a crucial window into a highly volatile complication in coronary artery disease. I mean, for decades, the gold standard for severe multivessel disease has been coronary artery bypass grafting.
Right, the classic CABG procedure.
Exactly. Surgeons bypass the native blockages by harvesting a vessel, often the saphenous vein from the leg, and suturing it to the aorta and the coronary artery. But the medical community has long wrestled with the fact that these venous grafts have a finite lifespan.
They don't last forever.
No, they don't.
Yeah.
And this study doesn't just look at 10 years of raw outcome data from a tertiary care center. The accompanying literature review really explains the underlying mechanical and, well, biological challenges of intervening when these specific grafts inevitably fail.
Okay, let's unpack this foundational problem first. I think an informed cardiology audience understands that intervening on a native coronary artery is standard practice.
Sure.
But intervening on a degenerating saphenous vein graft, an SVG, is notoriously treacherous. If we go back to that garden hose analogy, the fundamental anatomy of the vessel itself seems to be the core issue here.
That's spot on. The structural mismatch is, it's profound.
Because the saphenous vein evolved to live in the leg.
Right. It returns blood to the heart under very low pressure. It simply isn't engineered for the extreme high-velocity environment of the aorta.
Yeah.
Native coronary arteries have thick, muscular walls designed to handle systemic arterial pressure.
And the vein doesn't.
Exactly. A saphenous vein is thin-walled and lacks that robust muscular layer.
Right.
So when you transpose that vein into the arterial circulation, it undergoes severe mechanical stress.
The pressure just batters it.
It does. The endothelium of the inner lining of the vein becomes damaged almost immediately, and this triggers a cascade of intimal hyperplasia.
Which is what exactly?
Essentially, the vessel wall thickens abnormally to compensate for the pressure. Over the years, this accelerated deterioration creates an environment where atherosclerosis doesn't just develop, it develops aggressively and uniquely.
Yeah, and the literature review makes a sharp distinction between the plaque that forms in native arteries versus the plaque inside these older vein grafts.
It's completely different.
Right, because in a native artery, plaque often calcifies over decades. It becomes tough, fibrous, hard. But the plaque accumulating inside a saphenous vein graft is described as highly friable.
Highly friable, yes.
It's soft, incredibly lipid-rich, and essentially resembles a crumbly necrotic gruel, which just sounds awful.
It is awful. And this brings us to the mechanical nightmare for an interventional cardiologist.
Because you have to go in and fix it.
Right. When patient presents with a failing vein graft, the standard instinct might be to cross the lesion with a balloon, expand it, and place a metal stent.
But if the plaque in these old veins is like crumbly rust, and you go in with a balloon or a stent to smash it open, doesn't that debris just break off and wash downstream?
What's fascinating here is that you've just described the exact central antagonist of this whole procedure.
Yes.
When you apply outward radial force against that soft, friable, necrotic plaque, it doesn't just compress against the vessel wall like native calcified plaque would.
It breaks apart.
It shatters. Microscopic fragments of this lipid-rich debris shear off, enter the bloodstream, and wash downstream into the coronary circulation.
Wow. And that leads directly to distal embolization, right?
Exactly. The debris travels until the blood vessels taper down into the microscopic capillary beds feeding the myocardium, and it completely jams them up.
So the main bypass graft might look beautifully wide open on the angiogram?
Yep, the plumbing looks fixed.
But the patient continues to experience ischemia because the capillary network is choked with debris.
Yes, it's the classic no-reflow phenomenon. And the mortality risks associated with no-reflow are exceptionally high. The myocardium is still starving for oxygen, and massive myocardial infarction or lethal arrhythmias frequently follow.
So this specific threat, this distal embolization of friable plaque, is really the main villain in the evolution of SVG interventions.
Without a doubt, medical protocols had to evolve specifically to outsmart this crumbly debris. And the transition of those protocols is exactly what Devashvili and Asher's retrospective study captures.
Well, if the underlying pathology is that volatile, the patients requiring these interventions must be incredibly fragile.
Well, they are.
I mean, the study captures a decade of data, reviewing 238 patients at a single tertiary care hospital between 2005 and 2015. And they divided these patients into two distinct eras, right?
Yes, Group A from 2005 to 2009, and Group B from 2010 to 2015.
And looking at the baseline demographics of this cohort, it really highlights just how sick this population was.
The comorbidities are severe, and they play a direct role in the accelerated degradation of these grafts. The cohort is 95% male with a mean age of 68.
And the rates of other diseases are huge.
Very huge.
Yeah.
Over 74% suffered from hypertension, and 56% had diabetes mellitus.
And how does that affect the vein graft specifically?
Well, from a pathophysiological standpoint, diabetes induces chronic endothelial dysfunction. It impairs the vessel's ability to produce nitric oxide, which normally protects against plaque formation.
Oh, I see.
So you combine that biochemical vulnerability with the mechanical shear stress of systemic hypertension, and those thin-walled saphenous veins deteriorate exponentially faster.
Wait, 99% of these patients had a previous myocardial infarction, and 62% were admitted for acute coronary syndrome. These aren't just routine checkups, these are absolute emergencies.
Exactly. These are patients crashing with acute ischemia. Furthermore, over this 10-year observation period, the time elapsed since their initial bypass surgeries was actually increasing.
So the grafts were getting older.
Right. Cardiologists in the later era, Group B, were intervening on older grafts compared to Group A. The veins had been deteriorating for a longer duration, meaning the plaque burden was larger, softer, and way more prone to distal embolization.
So if the patients are older, presenting with severe comorbidities, and their venous grafts are further along in the decay process, the logical expectation is that procedural complication rates should skyrocket.
You would think so, but the complication rates dropped.
That's amazing. Despite treating an arguably higher-risk demographic with older, more fragile grafts, the clinical outcomes actually improved from the 2005 era to the 2010 era.
They did. The mortality complication metrics declined.
And that cause and effect relationship points entirely to a shift in the tools and techniques, right? The interventional cardiologists clearly deployed better technology to counteract the decaying biology.
The statistical shifts in the procedural data confirm that exact evolution. The utilization of specific protective technologies changed dramatically between the two eras.
Let's look at those numbers.
In Group A, embolic protection devices were used in only 9.5% of the procedures. But by Group B, their use surged to 36.4%.
That's a massive jump.
Yeah. And similarly, the deployment of covered stents increased from a mere 2.1% in the early cohort to nearly 19% in the later cohort.
Here's where it gets really interesting for me, just thinking about the mechanical engineering of these tools. A standard bare metal stent operates like a microscopic chain link fence, right?
It's a great way to visualize it.
You expand it inside the vessel to scaffold the walls open, but if the wall is lined with that soft necrotic gruel we discussed, the plaque simply prolapses.
It pushes right through.
Right, it squishes right through the open struts of the chain link fence and breaks off into the bloodstream. But a covered stent, like the EPTFE covered stents referenced in the study, operates fundamentally differently.
Very differently.
It is essentially a solid retaining wall. A microporous membrane encapsulates the metal struts, physically trapping the friable plaque against the vessel wall so nothing can prolapse through.
Exactly. The covered stent addresses the issue of plaque extrusion right at the site of the lesion.
But what about the embolic protection device, the EPD?
Well, the EPD is designed to manage the debris that is inevitably dislodged during the initial crossing and ballooning of the lesion. It is, functionally, a microscopic filtration net deployed downstream of the blockage.
So they put a net in the blood vessel.
Yes, Before the balloon or stent is ever expanded, this net is opened in the healthy portion of the vessel. So when the lesion is dilated and that crumbly plaque shatters, the EPD captures the embolic debris.
Wow.
And once the stent is safely in place, the net is collapsed, securely trapping the debris inside, and it is withdrawn from the patient's body.
So if this retaining wall and this tiny microscopic net are so effective, why wasn't everyone just using these back in 2005?
This raises an important question, and it's a massive mechanical paradox that the literature review touches upon. To deploy this net downstream of the lesion, the cardiologist first has to push the closed, undeployed device through the very crumbly, volatile blockage they are trying to protect against.
Oh, I didn't even think of that.
Right. How do you navigate a foreign object through a necrotic plaque without the mechanical friction of the wire knocking the plaque loose?
Which would cause the exact distal embolization the net is meant to prevent.
Exactly. That paradox is precisely why the adoption rate was only 9.5% in Group A. Early EPDs had bulkier crossing profiles. Pushing them through tight, friable lesions was inherently risky.
So they needed booger engineering.
Yes, engineers had to develop ultra-thin, highly lubricious guide wires. And in some extremely high-risk cases, cardiologists actually utilized a proximal occlusion technique instead of a distal filter.
How does that work?
They inflate a balloon before the lesion, temporarily stopping blood flow entirely. They cross the lesion, perform the intervention, aspirate the stagnant blood and debris with a catheter, and then deflate the proximal balloon to restore flow.
That sounds incredibly stressful.
It is a highly complex maneuver requiring immense skill.
Well, that definitely explains the gradual adoption curve. It wasn't just about waiting for the hospitals to purchase the nets. It was about the medical community mastering the insertion mechanics and waiting for the clinical trials to validate the risk-to-reward ratio.
Precisely. And the study's literature review explicitly mentions trials like the SAFER trial.
What did that trial show?
It was pivotal in proving that the benefits of navigating those EPDs through the lesions absolutely outweighed the crossing risks, ultimately reducing adverse cardiac events by nearly 50% in SVG interventions.
50% is huge.
It is. The literature review also highlights the profound debate surrounding the stents themselves, which further explains the delayed adoption seen in Group A.
Right, because in 2005, drug-eluting stents were revolutionizing native coronary interventions, weren't they?
They were. These stents are coated with anti-proliferative medications like paclitaxel or sirolimus, which inhibit the smooth muscle cell proliferation that causes restenosis, or the re-narrowing of the vessel.
So naturally, cardiologists assumed they would be equally miraculous in Saphenous vein grafts.
They did. But the biology of the vein graft reacted differently to the medication than a native artery would.
How so?
Well, the delayed RISK trial, which is heavily cited in this context, showed deeply concerning data regarding early-generation drug-eluting stents in SVGs. While they prevented immediate re-narrowing, they actually correlated with an increase in late mortality and late stent thrombosis.
Wait, really? The medication caused blood clots?
Indirectly, yes. The medication inhibited the endothelial cells from healing over the stent struts, leaving bare metal exposed to the bloodstream for years, which acts as a magnet for massive, sudden blood clots.
Oh, wow. So that is the crucial context for the data in this study. The low use of advanced stents in Group A wasn't a lack of innovation. It was a period of necessary clinical caution.
Exactly. The medical community was waiting for the engineering to mature and the long-term trial data to solidify.
And by the time we reached Group B, the technology had advanced.
Yes, we saw the advent of newer generation drug-eluting stents with more biocompatible polymers and thinner struts, alongside those EPTFE-covered stents. This gave operators the validated tools they needed to safely reconstruct these volatile vessels.
Catching the embolic debris and stabilizing the friable plaque kept the myocardium alive, which is obviously the primary victory here.
Absolutely.
But as we dig deeper into the procedural data comparing Group A and Group B, Doverishvili and Asher's study reveals a highly significant secondary victory.
And it's a surprising one.
It is. The evolution of these specific tools didn't just save the heart, it provided massive protection to the patient's kidneys.
The systemic interconnectedness of these high-stakes procedures becomes very apparent here. The study meticulously tracked the volume of contrast media utilized during these interventions.
And contrast media is the radiopaque iodine-based dye injected into the coronary circulation, right?
Yes. It absorbs X-rays, allowing the cardiologist to visualize the blood vessels, the lesion, and the blood flow in real time on the fluoroscopy monitor.
And looking at the data, the volume of contrast dye dropped substantially.
It really did.
In the early era, Group A, the average volume used was 186 milliliters per procedure. In the later era, Group B, that average fell to 137 milliliters.
A significant reduction.
And this reduction in volume directly correlated with a statistically significant drop in the incidence of acute kidney injury among the Group B patients. But I have to ask, I wouldn't normally connect a heart stent procedure to kidney health. Why does the amount of dye matter so much to a person coming in for a heart attack?
It's a great question. Contrast media is inherently nephrotoxic.
Meaning it's toxic to the kidney.
Right. When it passes through the kidneys, it induces a dual threat mechanism. First, it causes direct cellular toxicity to the renal tubular epithelial cells.
Okay.
Second, it alters renal hemodynamics. It causes vasoconstriction that leads to medullary ischemia, essentially starving the inner structures of the kidney of oxygen.
That sounds dangerous, but can a patient just flush it out?
A healthy patient can usually clear the dye with aggressive hydration. However, looking back at our cohort, these patients are 68 years old, heavily diabetic, and crucially, 17.2% of them presented with pre-existing chronic kidney disease.
So their baseline renal function is already severely compromised.
Exactly. The filtering units, the nephrons, are already operating at a deficit. Flushing 186 milliliters of nephrotoxic dye into that vulnerable system to save the heart graft frequently triggers contrast-induced nephropathy, or CIN.
So the cardiologist might successfully stent the failing bypass graft, but the toxic load throws the patient into acute renal failure.
Yes, which drastically increases their 30-day mortality risk and potentially leaves them dependent on dialysis.
That's a devastating trade-off. But the critical insight is understanding why the procedural tools dictated the volume of dye, isn't it?
It is. In the 2005 era, operating without embolic protection devices or covered stents was an exercise in extreme caution and anxiety.
Because they were terrified of the debris.
Right. A cardiologist would advance the wire, inject dye to confirm placement. They would dilate the balloon slightly, then inject more dye to check for distal embolization. They would deploy a bare metal stent, then inject again to ensure the friable black hadn't prolapsed through the struts.
Every single step required angiographic confirmation.
Because the risk of sudden, catastrophic no-reflow was omnipresent.
They were essentially flying blind through a minefield, constantly deploying flares to check their surroundings. But once the technology matured in Group B, the procedural workflow fundamentally changed.
Completely. The retaining walls and the safety nets provided a mechanical margin of safety.
So procedural confidence increased alongside procedural efficiency.
Exactly. Once the downstream filtration net was deployed, the operator knew the capillary beds were protected from debris. Once the covered stent was positioned, they knew the plaque was trapped.
So they didn't need to constantly check.
No, they no longer needed to perform constant piecemeal angiographic check-ins. The procedure became streamlined. Less time navigating unexpected complications meant fewer fluoroscopy runs, which meant significantly less contrast dye injected into the patient's bloodstream.
Which protected the kidneys.
Yes. This study empirically demonstrates that refining the mechanical tools in the coronary arteries provided profound systemic protection to the renal system.
So what does this all mean? When you step back and look at the entire narrative of this retrospective study, it fundamentally reframes how we view medical advancement. We have this cultural tendency to anticipate the sudden paradigm shift, a newly discovered molecule, or a miraculous surgical technique that changes everything overnight.
But that's rarely how it happens.
Right. The reality of interventional medicine, as proven by a decade of treating failing saphenous vein grafts, is often about relentless incremental mechanical refinement.
Step by step.
Exactly. It is about engineers and clinicians working in tandem to swap a chain link fence for a microporous retaining wall. It's about miniaturizing a filtration net so it can navigate a necrotic lesion inside a beating heart without dislodging the very debris it intends to catch.
And streamlining workflows to minimize toxic burdens.
Yes. It's incredible.
And, that process of refinement brings us to a compelling final thought, drawn from the depths of the literature review regarding the no-reflow phenomenon.
Okay. Lay it on me.
Despite the massive advancements in covered stents and distal protection nets between 2005 and 2015, distal embolization was not entirely eradicated.
Really? How so?
Well, microemboli can still occasionally bypass the filters, or more complexly, the sheer mechanical trauma of the intervention can cause the microscopic capillary beds to aggressively spasm and clamp shut, completely independent of any physical debris.
So the macroplumbing is perfectly secured, the debris is captured, but the microplumbing simply refuses to accept the blood flow due to trauma-induced vasospasm.
Exactly. And when mechanical engineering reaches its physical limits, interventionalists must pivot to pharmacology.
Mm.
To combat severe microvascular spasm, cardiologists administer powerful vasodilators directly into the coronary circulation.
Like what?
They utilize drugs like adenosine, which hyperpolarizes the cell membranes of the vascular smooth muscle, forcing the vessels to dilate. Or they deploy verapamil, a calcium channel blocker that prevents the influx of calcium required for smooth muscle contraction, literally paralyzing the capillary walls in an open, relaxed state.
Wow. The transition from macroscopic nets to microscopic cellular manipulation is incredible. I mean, we spent the last few decades mastering the major pipelines of the human body, bypassing the aorta, stenting the main branches, physically trapping the plaque. But as this retrospective study so perfectly illustrates, as we perfect those large-scale mechanics, the true frontier of cardiovascular medicine is shifting deeper. It is about understanding, protecting, and pharmacologically navigating the invisible cellular capillary networks that ultimately sustain the myocardium. Thank you for listening to the GMJ podcast. For a full and detailed discussion of the topic presented in this episode, we invite you to consult the original article published in the Georgian Medical Journal. A direct link is provided in the episode description. We look forward to continuing these scholarly discussions in future episodes.